Thanks everyone for taking time out to join us this morning. I think we have a really awesome presentation and webinar and learning session set up for all of you. As we talked about on the last one, if you're able to join one of our last two learning sessions, this is really meant, as I say, as a learning session to really kind of show and highlight not only a lot of the work that's being done on the hyperfine system and the low field system across various members of the Unity network, but also to act as a learning session for many of you to see, how the system is being used elsewhere, to really get a sense of what the images look like, what different pathologies look like. And the hope is actually at the end of many of these, we'll be able to put these together as a large collection and make that available as a public resource to what some of these indications and pathologies look like at low field. As we mentioned on the last one, we had last two sessions led by Dr. Eddie Knopp, who's the Chief Medical Officer at Hyperfine, who ran us through a number of really amazing cases, a number of different pathologies and indications, which has been great. But we really wanted to also now begin to highlight some of the really early scans and pediatric scans, going right down to the neonatal stage, given that a lot of our upcoming studies within the Unity network are going to focus on neonatal stroke, HIE, and these sorts of indications. And so for that, we've invited in a special guest, well, actually a whole group of them now. So we have doctors Hemmen Sabir, Anna and Sabir from the University of Bonn and Bonn University Hospital. So an amazing group who've been using the hyperfine system for about probably, I guess, 3 years, almost 4 years in Germany. And really, I think of all the folks that I get to interact with on the clinical side of Unity, Hemmen and his team are amazing. They pretty much have used that scanner for everything. So we have a very, very small collection of scans to go through. But basically, if you could think of it, he's probably scanned a kid with it. So it's an amazing set of data that he has. For those who are able to find it on or follow along, so if you've registered and you have an account on Collective Minds, if you go into Collective Minds into Collections and then choose Collections and Unity, and then scroll down, you'll see Unity webinar number 3 with Dr. Knopp and Professor Hemmen. And so that's one that we're going to be sort of drawing scans through and sessions and cases through. But don't feel that you have to follow along in real time. We'll be bringing the cases up as we go. And Professor Sabir and his team will be walking through, giving a little bit of the clinical background for each of the cases, and then walking through the scans. And as I say, there's a wide selection starting from neonates and then moving all the way up even through to some older kiddos and kiddos on ECMO and whatnot. So a really great set of cases to look for. As we go along, many of you, if you have questions, you can either feel free to put them into the chat or into the Q&A. We'll be monitoring that. So myself and Professor Williams will be monitoring that. And if you need or wish to speak at the end, so we'll probably break this up so that we'll have a discussion after each of the cases. If you wish to have a chat or say anything during that, just raise your hand and then we will unmute you. So just keep that in mind as we go along. Okay, so without further ado, I'm going to hand over to our two co-presenters, Dr. Knopp and Professor Sabir, as well as Anna and Sabine from the University of Bonn. So over to you, and thanks again, everyone, for joining us.
Thanks, Sean. So why don't I open up the first case,
Yeah.
and then you guys can kind of discuss it.
Yes, thank you very much, Sean, for this very kind introduction. Welcome, everybody. We're very happy to start off probably light with a light case. So this is a newborn baby. He was admitted to our hospital on the second day of life when his mother at home realized that he had some abnormal movement, and she described it as being fits, and he was in a stable condition when he was admitted. However, when we've seen him on our A&E department, we also had the feeling that he had some fits, and that's why we wanted to take him to the high field scanner, but that was occupied by that time. And so we started off putting him into the hyperfine to see what was going on, because we couldn't see anything suspicious on the ultrasound that we did on the rapid point of care ultrasound in the A&E department. So the first thing that we wanted to see, of course, in this acute thing, because it seemed to be something very acutely ongoing, was, is there a bleed, a cerebral bleed that we couldn't see, maybe on the fossa posterior that we were missing on the ultrasound, or if there would be a cerebellar hemorrhage. And then on the other side, of course, was there any changes in diffusion weighted images where we could see some suspicion of something that was going on in the brain? And Eddie, that would probably be the questions that I would ask you as a radiologist. Do you see anything suspicious on these low field images?
Okay, so looking at this is the axial flare image. Now we're at the superior aspect of the brain. And looking down, again, in neonates, it's a little difficult because of the lack of myelination, but maybe there's nothing striking in this regard. The ventricular system is normal. There's no extraaxial collection. There's no real signal abnormality, again, on the flare image. However, and there's always a however, right? When we go to diffusion weighted imaging, it becomes very obvious. Let me just kind of window it. Start at the bottom, coming up, right? Cerebellum, inferior temporal lobes as we come higher up. Again, this is the DWI p-value of 900. The expectation for acute diffusion abnormality would be high signal. And lo and behold, within the mesial aspect of the left thalamus, there is a focus of increased signal corresponding to acute infarct. In addition, as we come up to the superior aspect of the brain, we're also seeing additional areas of restricted diffusion in the superior right greater than left parietal lobes. It's always nice to confirm that on the apparent diffusion coefficient map, which is an actual manifestation of that motion of water, how much things are moving. So if it's not moving as significantly, it's going to decrease in its signal. The coefficient of diffusion is lower. It's going to give us a black signal, whereas it's white on DWI and black on ADC. And lo and behold, what we saw on the DWI is restricted on the ADC. So it is consistent with multiple infarcts, bilateral in different vascular territories.
Then we confirm, just because we need to confirm on 3T, and we performed a 3T scan on this baby, but because we also wanted to see what is the progression of the infarct, we also did a second hyperfine 5 days later.
Is the Hemmen, is the 3T before the 5-day follow-up, or?
Yeah.
Okay, so let's look at the 3T. Hold it, gotta go back. I lost this. We'll open up the 3T. And it's rotated, and I'm not quite sure. I think we shift in R or something. Oh, no, we don't want it upside down. There we go. I don't know what sequences are here. It looks like it's just a T1 sequence. Did you do a full 3T exam or just the T1, guys?
And we did a full 3T exam.
Okay.
Yeah, I think if you load the other ones, there should be a flare, T2, and some others in there. Yeah. And an ADC map.
Okay. Load it. So the T2, which is slowly loading. And we'll just jump to the DWI if we can find it. Okay. Seems the viewer doesn't, well, here we go. Doesn't like the 3T, is too much resolution in the data. But here we can already see there is some signal change in that mesial anterior thalamus on the left. And coming higher up, we're kind of seeing the same thing where we saw infarct before. I don't see. Let's just go back to the, if you don't mind, I'm going to go back to the
Yeah,
hyperfine.
maybe we can just jump to the 5 day afterwards, just because, the 3T is not so important here, just because we've seen already what we wanted to see on low field. The
Okay,
question was just, will it progress over the time? Will it get
gotcha.
worse?
We'll look at this one. It seems to be more forgiving with so let's just cut to the chase. And again, so this is the DWI B900. So again, acute infarct is going to be hyper intense, bright on the DWI. And what we're seeing now, 5 days later, is decreased in that extent of that DWI signal abnormality, as well as what we saw in the high parietal right greater than left lobes. Looking at the ADC, where the expectation is decreased signal intensity because the water is blocked from moving. So it's giving you a decreased signal, seeing kind of the same thing, but looks like a normal progression of the infarct in that it's kind of resolving. Let me see if we can see it on a conventional sequence. See what Flair's showing us. And again, the DWI changes are going to occur before the more conventional changes. On the Flair, you get a sense that maybe something's going on. There's a T2 sequence. I don't know if we'll see anything there. Not really, but I think what we saw is acute infarct on day whatever, we'll call it day 1. 5 days later, infarct present, but resolving, kind of a normal path of expectation. When was the event versus the first scan? How many hours, days, minutes?
Well, when the mother called the ambulance and came to the A&E department because she'd seen abnormal movements being fixed and respectively.
Okay,
And
so
then
within the first,
it was just within like 2 or 3 hours.
oh, okay, great. So it's kind of normal. The resolution pattern is a little quick, but can't argue with it.
Good. Okay, that was probably something just to warm you up, everybody. So the next case is presented by Anne.
Yes.
We want to do the septic shock ECMO?
Yes, exactly. You
Okay.
can start first ultra low field. So the second case was a 1-year-old boy who was transferred from another hospital because he had septic shock and was in a very bad condition. He had oxygen saturation from about 80% for several hours and also arterial hypotension for several hours, and then was sent to us and we put him on ECMO therapy. And yeah, he was on ECMO therapy for 5 days. And then we stopped ECMO therapy. And always when we stop ECMO therapy, there's the question when he again worsens, shall we restart ECMO or not? And so just after stop of ECMO therapy, we did this ultra-low field scan because we wanted to know what is his prognosis. Shall we restart ECMO when he clinically worsens or not? And he was still intubated and on dialysis, so we couldn't get him to high field MRI. So ultra low field MRI was the only way for us to see at his brain. Yeah, and we would ask like our radiologist, what can you see on him? Like, what do you expect for his further prognosis?
Okay. Now he's a neonate just recently born?
No, he's 1 year old.
He's 1 year old, okay.
Yes.
There's this extracranial, soft tissue swelling.
Mm-hmm.
I don't know, it was neonate, it could be a cephalohematoma, but intraparenchymally on this sequence and nothing is being labeled. The ventricular system looks okay. It looks like maybe there's an abnormal mass back here. We can see that the there's an asymmetric appearance, left versus right ventricular system, with the posterior aspect of the right being somewhat compressed. Let's see what this is. This looks like B0. This is. I have to find a sequence that's relevant.
I think the DWI is the last sequence.
The last? Okay, let's try that. And let's rotate it so we're not all turning our heads. Okay. So this is the B900. There's some motion here, but clearly we see multiple areas scattered throughout the brain of restricted diffusion, consistent with acute ischemia, cortical, subcortical.
Yes, exactly. We did see the same. So we would have decided not to put him again on ECMO, but he, recovered himself, and we could go to 3T MRI, I think, 3 days later, which is also that's
This one?
This one, yes.
Hopefully this will load better. Let's just see what we got. So
Yeah,
3T. It's still. I don't know why we're getting this alternating pattern of the ventricles dropping out. Pick something else. The 3T images look like they haven't come over properly. Maybe that's...
So for us, what we learned from this case was that
Okay, here we go.
this case actually helped us to counsel the parents, like to say, do we again start very intensive therapy if he gets any worse on a clinical side, or shall we like restore therapy because we see massive brain injury?
Okay, so again, what Anna's saying, we're seeing extensive bright signal change that's consistent with the infarct that we kind of saw before. But in addition, this is 3T, so it's much more sensitive to blood product and susceptibility. So we're seeing evidence of hemorrhage within the brain as well. So would that be a contraindication to you putting him back on ECMO? Or
Yeah, if we would see these multiple infarcts and multiple bleeds, and especially diffusion changes, then if he would deteriorate, and we would probably not put him back on ECMO, but then redirect care.
it looks like that's what we're dealing with.
Yeah, so we think so we did further scan him, didn't we?
Yeah,
so
we did.
on low field to see how does the brain injury progress, because this was some days after, like 4 or 5 days after the first scan. Then he came off his hemodialysis, so he was able to be moved to 3T, but still he was quite sick. So we came back to our pediatric intensive care unit, and because we wanted to see the progression of the injury, we still put him into hyperfine 2 more times.
Yeah, the first one was actually 2 months after the first ultra low field.
2 months. Okay.
Yes, because that was the time point where he was again clinically deteriorating, and the question was like, what are we going to do with him? And that was 2 months later.
Okay, let me try to find sequences that show us something. Okay. Let me move this. Oops. Okay, there we go. So what we see here, quite obviously, is brain parenchyma, subarachnoid space, And here we have a large area of bright signal outside of the subarachnoid space in the subdural space. So it's a subdural hematoma. It's slightly pushing on the brain parenchyma itself. However, what we like to assess the degree of mass effect and pressure, we talk about how the midline of the brain is shifted to the right or to the left. In this case, we can draw a line here. And while there's mass effect, there's not significant shift to the midline. A lot of that is due to the fact that there's a lot of room in this skull. In an adult skull, skulls of our size, the brain is fairly tightly enclosed and would be more susceptible to a subdural such as this size with pushing on the brain, which can have significant other manifestations. But the extent of this acute blood product, we can see almost involving the entire right side of the skull itself. And I guess that we didn't see any evidence of that before.
No.
Did anything happen in between, or this is
Well,
spontaneous or thought to be?
he was in several hospitals, like in between. Like first we had him in our hospital, then sent him to neurorehabilitation. There he got another infection, was sent to another hospital first, was again intubated, and then came back to us. So I think there was a lot of intensive care medicine done with him, and he also had a lot of transport, also with helicopter.
It also looks like there's signal change in the parenchyma in the left temporal occipital lobe as well.
Yeah, we performed a third scan then afterwards.
Yeah, 2 weeks later.
2 weeks later after this one.
Time point 3.
And that was only a very short scan, which shows a lot of motion artifact, because that time he was awake and he was very, very couldn't be, was moving a lot, and so we had to do this MRI very quickly and fast.
So I think if you recall what it looks like, his ventricular system is now enlarging as it had been the 3 days before. So he's developing hydrocephalus. Extraaxial collection is present. I thought it was on the right side before, but the images might have been inverted since we have to rotate these things. And the parenchyma is tough to assess. The indistinctness of the brain is due to patient motion. Let's see what this is. This is not helpful.
Yeah.
And the first one, rotate it.
Yeah, and that was the time point where we again talked to the parents and said, I think it's the time not to further go to intensive care units, but to limit the therapy. And then he was again sent to his home hospital, where he then passed away several weeks later.
Gotcha. So basically, without the ability to image him routinely with the hyperfine, would you have changed your recommendations to the parents?
Yeah, I think in the first case, we would have maybe said if he again worsens, we would go back to ECMO. And also in the second and third case, we would have maybe said, okay, stay at our intensive care unit and we will do everything we can. But like this.
Gotcha.
Yeah.
Okay. Hemmen, any comments or anything, or we'll move on to the next?
No, we can, I mean, even though this is a very sad case, it shows what also hyperfine can help us with, counseling parents. And
right, exactly.
making decisions in a, very high intensive care setting where we can offer everything on technical therapy, but sometimes, taking him to 3 Tesla scanner all the time to do this means he needs to be intubated and, being very stressed rather than, having a hyperfine to just see how brain damaged is he and what will we offer the parents on intensive care medicine, I think is a clear and positive effect that we can have from ultra field images.
No, absolutely. It's not necessarily the outcome you want, but I see the same thing from our customers here in the United States, both adult and pediatrics, in the setting of global anoxia, just to prognosticate and to show the family, parents or otherwise, the extent and significance of the injury. Do you guys show the families what the images look like?
Yeah.
Yes,
Yeah,
and it helps a
absolutely.
lot because they can like visualize what is going on, and it's easier than to read an EEG if you're not like
Right. They're not gonna, right. They're gonna see
And
squiggles.
yeah, and they're normally with us when we perform the images, so they
Right.
see
No,
exactly what
as
we
they were a
do.
couple weeks
Yeah,
ago when we were watching,
yeah.
when I had the pleasure and privilege of observing you guys. Okay.
Maybe we can move to the next one.
we move to the
Okay.
next case, and that's a. Can we maybe start with the TP1, like with the 3T?
This one?
Yes. That's a case which is probably quite common. We had a 35-year-old mother who got her second child in 36 weeks of gestation. And already before birth, it was known that this child has congenital hydrocephalus. So they were testing for CMV infection, for toxoplasma parvovirus. There was like a ultrasound made while the baby still was, before it was born. And there was also a fetal MRI, and we didn't find any reason for this congenital hydrocephalus. So after birth, we again did a 3T MRI, and this is this MRI. And if you look at the brainstem, I think you will see what caused this hydrocephalus.
Okay, so obviously, while we're waiting for this to load, it seems to be taking a little while. Massive hydrocephalus to use a radiologic term, it's even extensive, what we call a colpocephalic appearance, where the posterior aspect of the ventricles is expanded and dilated more than the anterior aspect of the ventricles, right? So normally they should be symmetric. Here, there's just a thin rim of cortical tissue overlying these blown out lateral ventricles. You see the remnants of the septum pellucidum at this point. We come higher up, and that's basically what we see. There is some motion here, but we're going to go to the brainstem. Here's third ventricle, also markedly enlarged. And coming down now, we're at the midbrain, top of the cerebellum. Okay,
You go a bit more up.
a bit more up. See, now interestingly, and I think I know where this is going to go, is the fourth ventricle is relatively normal in size compared to the lateral ventricles that are blown up like massive balloons. So remember, the CSF should be contiguous between the lateral ventricles to the third ventricle to the fourth ventricle through the aqueduct. So we should be able to see, and I'm going to presume that we're not, that all of a sudden we're losing that CSF signal here. Could be a manifestation of a discrete lesion or aqueductal stenosis, as we say, where the aqueduct is blocked and this normal flow patterns of CSF produced by the choroid and the lateral ventricles through the foramen Monro into the third ventricle, down the aqueduct, through the fourth, and then out is not possible. It's blocked. I don't know did you guys do a sagittal?
Yeah, we also did a sagittal.
Okay, I'm gonna have to find it. So I don't know if we'll have the resolution. I don't know what.
But we can also go to the hyperfine scan, which was performed several days later, because I think maybe it's a bit more obvious to see the pathology in the hyperfine.
Oh,
Not
okay,
because
that's
it's
good.
sharper, but because then something happened to the pathology.
Oh,
It's
gotcha.
H99 one, yes,
This
exactly.
one?
Yeah. And yeah. So I think the clue is to go to the sagittal, as you just mentioned.
Find it. Here's the sagittal. I don't see it.
I think it's the T2 is isotropic, so you can just
Okay.
yeah, and the T1 as well.
Let's do. Pick this one. Okay, we're still a little bit rotated, but we try to. So we're sagittal. Here's the globe, posterior part of the head. Fourth ventricle, and it looks like there's a lesion between the posterior portion of the third ventricle and the fourth ventricle. On this, I don't quite see the resolution, but looks like if I was looking at this, I would say that there's a tectal lesion, possibly tectal glioma. I don't know if there's a better sequence. And if you know, let's try.
Yeah, we also first thought it might be a glioma, but then we looked in all sequences like T1, T2, and diffusion. And yeah.
Looks basically the same. Which sequence do you want to look at now?
T1.
Look in the
I think
sagittal.
it's better visible in T1 than in T2, to be honest, because it has a bright signal in T1. Is this T1? I think this is the diffusion sequence, isn't it?
Nothing is labeled. It's always helpful.
No, that's
Yeah, this looks like T1.
that's T1, yeah. Yes, so we did see this lesion, which was like short radiological features of a ATRT tumor, so atypical teratoid rhabdoid tumor.
Atypical teratoid rhabdoid tumor.
Yes, exactly. But what we also did see, yeah, can you go a bit, can you see in the back of the cerebellum? Yes.
Right.
We
So
also
the
saw-
ATRTs are highly aggressive brainstem tumors, atypical, spread with a prognosis of barely anything, at least from my experience.
Yes, and this is what we also did see in this scan. Like we knew before from the 3T that there was a suspected tumor, but what we didn't know was what we now learned from the ultra-low field, which was only performed some days later. We got several metastases that could be detected only using ultra-low field.
How old was this child?
This child was at that time 11 days old at this.
11 days old. Did you try to put a ventricular catheter in?
And we already did like the day before, I think it was done.
And did you send the CSF for cytology?
Yes, we did send, but that was before metastasis because it was, I think the high field scan was done on the 3rd day of life. Then on the 4th day of life, we did the shunt, and we didn't find anything in the liver.
CSF?
Yeah, and then on the 11th day of life, we did this 3T scan, which then showed metastasis.
Gotcha. Okay.
And it showed several metastases. Like you can see the one in the cerebellum, but you can also see one in periventricular and
Right. Supratentorially as well.
yeah.
And the thing is that we saw it first on low field, and then confirmed.
Yeah.
Yeah.
That's quite interesting. Want to move to another one?
Yeah,
Yeah.
for sure.
Maybe we move to the one that Sabir can present.
Okay.
That is
Share.
a 70-year-old boy.
Which one, Sabia?
I think
This
it's
one?
the last one. Yes.
Teenager?
Yes. So
Which would you like to see first?
maybe the ultra-low field first. Teenager with suspected stroke. Yes.
Okay.
So this is a 70-year-old boy who came from another hospital. It was like a smaller hospital. He had like headache and double vision, and he was like very, very big. He weighed like 100 kilograms, And so he came to our hospital because in this external hospital they did like a 3T and saw a stroke. So he on this point he has like hemiparesis like on the right side. And so we did like he came like on the afternoon, and in the evening we did like an ultra low field. So you see, or maybe you can say what you see.
Okay, so these are his T2s. Let me try to make it so we can fit it in. So his axial T2, superior to inferior. And when looking at this, any radiologist, you look for symmetry, right? The brain is great in that regard. The right side should look like the left side. It looks like there's signal change here within the right posterior frontal anterior parietal lobes. You said his weakness was left-sided?
It was on the right side.
On the right side, okay. Well,
The thing that was quite striking was that he had a clinical image or a picture that didn't fit to his image that we had.
but you're saying he's had right-sided
He
symptoms,
had a right-sided
pathology on the right.
hemiplegia. Say it again. He had a right-sided hemiplegia, and his image showed a right-sided.
Everything we've seen is right-sided.
So that's why we could only do T1 and T2, I think, when he was admitted, because he was scared. But then the next morning, and we had a 3T image. And then the next morning, what we did is that we put him into the scanner again.
So this follow-up?
Yeah. Because we wanted to see his diffusion. We had his diffusion from his first day when he was external still.
Well, again, the pathology is posterior and more right than left.
Mhm.
Let me, what's this? This will show us, okay.
So the question was, is there anything that developed on the left side that you could see? Which would then bring us into the case that we think he has a right-sided posterior lobe infarction or pathology, but does he have anything on his left side that could explain his clinical performance?
So it looks like he's got bilateral extraaxial collections, but that's not doing anything. And on the left, it looks like there's evidence of prior ischemia here.
Exactly. And that's what we couldn't see on the first 3T. So we used the hyperfine to then say that he must have something that progresses. So that's why we put him into a second 3T scan.
Okay, let's see if we can find that. Which is first.
It's a
Because that's his
This
first
one.
3T, and that's his then. So we were suspecting that he had a progression of his stroke, which could explain his clinical deterioration and his clinical hemiplegia. That's why we said, okay, let's take a look to see. That's why the clinicians then said, because he was then transferred to the adult department, because we as pediatricians said, this guy's too big for us.
Right, be bigger than you are, then.
Exactly. So that's why then they were a bit scared to say, okay, so it seems on swoop he has a progression of infarct. And can we really confirm this on 3T now? Because he has an ongoing disease.
Right. So what we saw initially was the right-sided disease. On that subsequent swoop scan, we saw a left-sided disease as well. And it's scattered, it's bilateral. Did you assess for a proximal etiology, cardiac or?
We did. So he had TE, and I think they didn't find anything. So at the end of the day, what he had was a small vasculitis.
Mm.
And that's basically his findings that we had on and during his angiography. That's what they then found.
Gotcha.
But what we thought was really striking, that we could see something on the progression of injury that we saw on hyperfine, that we then confirmed on 3T, which if I would only have hyperfine, I would trust the image, then I could say, I mean, this is the progression of the injury. We have to think what is going on, because he's also presenting with a pathology that, doesn't make sense to
Doesn't
what
make
he's seeing.
sense for the findings, right?
Okay, I think, Sean, there was some questions, wasn't there?
Yeah. So I was just gonna, I mean, this has been awesome. A beautiful overview of some of the larger sessions that you've had. And so, I think there's some new questions coming through. I think, so I don't know if we want to unmute Sinjuti, who just put up a question, or Samantha from Bangladesh, who's talking a little bit about some of the signal issues she might be having.
I'm going to put us on a big screen right now.
Perfect. But beyond that, I think, if there's anyone who has any questions, I think just as we've kind of gone through on some of the work that's been done before just jumping into another case. But if there's been any questions, if you do put them up in the chat, or lift up your hand using the react button or whatnot, then we can bring them down. I guess one question that just popped up is, are serial scans always required in asymptomatic neonates? Have you found that to be super useful, either Eddie or Hemmen, in terms of getting a sense of what's happening in the kiddo versus just a single cross section? I guess that obviously depends on the indication, right, and what the child presents with. But maybe your thoughts would be great.
Hemmen?
Yeah, so we've scanned a lot of babies here without pathology, just normal babies, just because we want, during the time that we learned more about imaging and learned about, how to optimize the imaging, we went on our postnatal ward and talked to the parents, and then got consent to scan normal babies. And some of them we scanned serially, but during a short time. So just between a week, let's say day 2 and then day 5 or day 7 again. And I think we did this out of a research purpose. I think it's not very useful, to be honest.
If they're asymptomatic, there's a saying that at least I use a lot. If it ain't broke, don't fix it. So if there's nothing wrong, you're not going to do anything. You're not going to see anything differently. So basically, same thing.
Cool. Yeah, I think.
But that was the question requiring normal babies, asymptomatic babies, right?
Yeah. I think obviously when you get into symptomatic kiddos, I think we're now starting to see the value in obviously following progression, with even potentially increased sensitivity on the lower field system than what you have on the higher field system, and that could actually just be because you can, you obviously have greater access potentially to the lower field system. You can use it more often, and that might give you more information than trying to get them into a high field system. So it's almost a different way of thinking about MR, more as a longitudinal triage system to flag potential changes that are happening, and then, as you say, potentially confirm on a high field system. But it's not something you typically think of. Normally we would think of doing everything at high field and then trying to confirm at low field, and it seems now that or see if you can see it at low field. And now it's almost the opposite. We can see it at low field. Can we now see it at high field? And that seems to be up in the air, which I think is a cool finding.
Yeah, I mean, we've used a lot of it now, just as in some of the cases we've shown you, just to confirm the progression of the injury, especially, during times when we can't move the baby or the child, because, we've got so much machinery running, and, it's a massive effort to put the child onto the transport trolley and transport it on into the 3T era, when maybe some of the machinery we're using is not even capable to go into a high field system.
Yeah, I wonder if you want to maybe comment on that a little bit, because I know one of the groups that we invited specifically to this webinar and learning session was individuals who, in some of our sites that are part of the NIH Global Network, that will be part of a large-scale study looking at HIE and obviously early neonatal brain injury. And one thing that we has not been terribly well done in that case is actually track the longitudinal progression of injury, and whether that progression of injury might be more indicative of long-term outcome than a particular scan. You know, how do you know what time point to actually do a single scan, and then so how can you possibly relate that potentially to long-term outcomes given the variability and the temporal changes? So wondering if there's any thoughts on you know, again, your experience obviously in being able to put kiddos into the system serially and really get really beautiful data looking at, as you say, the progression of injury. And do you think that's going to be an area of sizable value as we go forward with some of these studies?
Absolutely. I think, you know, what we've seen, so we've done one case study where we've had a child which came in after suspected sudden infant death at home, and it was resuscitated, and we had a very acute injury because the time between the child was put to bed and found it was 6 or 5 months old was less than an hour. So, and then the mother found him not breathing. They started resuscitation, and they had restoration of circulation after, I think, 30 minutes. He was brought to us, and we scanned him on a daily basis, so every day, to see the progression of injury. Just because this wouldn't ever be feasible on 3T. And then we've seen the changes in diffusion. And I think, you know, you could use it to say, okay, how long has the injury been going on? And what we can use it for sure is, I think, you know, in a global network setting, if we don't know exactly when was the onset of the hypoxic ischemic event and the delivery, is it subacute injury, is it chronic injury, is it partial chronic injury? You see the diffusion changes, and as more as we learn about them, and we compare them with 3T, we confirm that everything that is learned or known on 3T, you know, having more cortical highlighting, not acute injury in the basal ganglia, hippocampal region, indicates, you know, a chronic asphyxia rather than an acute event, which would probably not be so susceptible to the treatment. So I think you could use it on early scan while the baby is stabilized or stabilizing to really see, okay, when was the onset of the injury?
Awesome. Yeah. And I don't know, Eddie, do you know of any group that in the US that's doing something similarly? I think, you know, Hemmen, you might be the only group doing that currently, but it's obviously something that we want to roll out across many of the Unity sites that are work
In the US, it's basically just an image in time. It's not that serial follow-up. And kind of as we indicated earlier, for prognostication, you know, the picture's worth 1,000 words. So you can kind of show the parents, the family, the extent of damage.
Right. And that kind of brings up, so, you know, there's a follow-up question about potential side effects of serial exposures. I think, you know, certainly the view of the MR community certainly has been that there's no, you know, major issues and risk of repeated MRI scans. If this was CT, it'd be a whole different kettle of fish. But certainly MRI work, and I know that there's been some interesting work done on that. You know, where they've had, for example, premature kiddos like twins, and one's been scanned and one has not been serially, and showed no major health impacts on the twin that was scanned repeatedly and whatnot. So I think the community is kind of happy with the idea that there's no major risk, and we've certainly not seen a major risk factor from serial scanning. So
you can actually extrapolate that, Sean, to the patterns and what's occurred with imaging fetal MR in the pregnant women. Whereas way back when it was like a no-no, absolutely stay away, da-da-da-da. And then people got more comfortable with it without any untoward effect on the, you know, then unborn, soon to be born child.
Yeah, that it always makes me laugh, given that at our institution where I was, are you pregnant was still a question on the screening form.
Still is.
Even though you're going in for a fetal scan, but you're being asked.
Are you pregnant? I hope so.
Yeah.
So I mean, there was one more question, I think, just coming up about, you know, the yeah, knowing pathology and learning about pathology is nice, but we need to learn something about the normal brain size. And I think this brings up a very important point, because that's an exercise that we did in the beginning. And we thought, okay, everything that we see on low field, is this really true? And I mean, the gold standard of neuroimaging in a neonate would be ultrasound.
Right.
So what Anna has done, she's done an extensive study to really measure anatomical structures on ultrasound in axial and coronal spaces, and then compare it to low field. And we did it blinded with 3 examiners. And you have a very, very, very standardized correlation, or very significant and very R-squared correlation between the ultrasound measures that we do in our standard measures of the size of the brain and different brain regions and low field. So basically, it's not an artificial image that we get, but it's really the volume of the structures that we see.
Yeah, I think that's a great point. And I think, just to amplify that a little bit, one of the big aspects, or one of the pillars beyond the clinical applications of low field of Unity has been to look at brain growth across multiple geographies. And what we can say is that from a lot of work on that, and Sharia, we're certainly happy to have you and make sure that we can invite you to some of our other calls that we have that sort of focus in on some of those results. But definitely there is a difference depending on where you're born as to, obviously brain size, brain for age, even correcting for overall physical size. So that seems to shift, whether you're in India, various Africa countries, Bangladesh, etc. But we certainly know that, and as Hemmen says, the really nice correlation back to either ultrasound or to 3T MRI that we've also been acquiring in some of this data as well. So we do have tools to help with that as well. So yeah, if you're trying to look for differences in ventricle volume, for example, we're certainly working to develop tools for that.
Yeah, we've standardized the scanners in terms of the acquisition protocols and the analysis pipelines, so that the same brain in different scanners across the world would produce the same results. So the opportunity to be able to model, as I say, local versus global differences, and for the first time create templates for Bangladesh, Ghana, Malawi, Botswana, Uganda, Kenya, you name it. And so they'll all be made available as part of this humanitarian license whenever possible. And if we can't make the raw images available, at least the summary statistics from those for total brain volume, white and gray, and so on, will be at your fingertips.
Yeah, something very similar akin to normal physical growth, height and weight, head circumference measures. I think we'll be working to be able to provide so that you could do either a regional or global Z score, for example, of white matter volume for child size, these sorts of things. So that's something that we're working towards. But a really good question. Any other? Oh, go ahead. Yeah, please.
Should we do one more case?
That'd be great. Yeah, let's it's like an encore. Yes, yeah, for sure.
Hey.
Like one quick one.
Share the screen.
But as you're getting one up, I'll just say, so the question that just popped up, is it possible to see nutrition or other interventional effects with hyperfine? And the answer to that is yes. So we have begun to see, for example, even impacts of anemia, so maternal anemia on infant brain development. We've also looked at other feeding studies looking at differences in as I say, different amounts of early childhood supplementation. That was a study that was done in Uganda, for example. So it is quite sensitive to those subtle changes that you might expect from either increased nutritional supplementation, increased calorie intake, or indeed alleviation of micronutrient deficiencies. Yep. And now back over to you guys for the encore performance.
David, what would you like?
So maybe this one, yeah. So basically, this was just the but
AVM?
maybe start with the 3T, because so he was a 4-year-old boy, and the thing that was striking with him was, he had acute headache at home, and which he had never had before, and he was then taken to the community pediatrician. He quickly then thought, okay, instead of just saying he has migraine or whatever, by his age of 4, they sent him over or transferred him for a 3T scan. And the scan was done, under sedation. And the thing was, would you think, or what did you see? Or do you see anything suspicious?
Oh yeah, I did in the 1 second it flashed by. Oh, so this is 3T. Hopefully one day the hyperfine swoop scanner will look similar. Trust me, it's getting really close. Uh, Axial T2. Now, when looking at a brain image, and we're looking, you just don't look at the brain parenchyma. So just look at this example per se. So we can see the cortex is a different shade of gray than the underlying white matter. We see the CSF around the brain, but we also see something in the CSF, little black dots. Well, these black dots are not giving us any signal intensity because they're vessels, and the blood within them is flowing rapidly and isn't subjected to the same magnetization properties as is the brain. So these are all flow voids, as they're known, in the brain. So one can assess the vascular nature of things even without an MRA sequence per se, using what we call black blood technique. So the blood here is flowing and it's black. And you can clearly see these vessels with exquisite detail on this 3T scan. As we come down, we're at the lateral ventricles. We can see the internal cerebral veins here. We can see middle cerebral arteries and the like. And let's just go down to the bottom. This is the confluence of the internal cerebral veins forming the vena galen, the venous confluence, very prominent, easy to see with this black blood technique. And now all of a sudden we're seeing additional smaller vessels in the posterior fossa, and you're gonna have to take my word on it, that we typically don't see normally, indicating that maybe something is going on here of a vascular nature with increased flow. Again, we're seeing that here, all in the perimesencephalic cistern coming down. Now we're seeing greater asymmetry on the right with additional squigglies, to use an American term, indicative of significant extensive additional vascularity and vessels. Here we can see a nice larger vessel, and this is all consistent with a malformation, an arterial venous malformation. We have feeding vessels here that are enlarged and draining veins centrally within the ventricular system in the fourth ventricle. And you get a sense here, right? You've all seen brain images of whatever field strength. You don't see all of these black dots. This is all vascular abnormality as part of this child's arterial venous malformation. When looking at brain imaging for this, you want to look for these flow voids, but what you also want to look for is, are there any changes in the adjacent brain parenchyma? Are we seeing edematous changes or volume loss where there's evidence of steel, the brain isn't getting enough nutrition, or the flow is backed up and there's cerebral edema? On this T2 image, I don't really see evidence of that. I just see this large posterior fossa arterial venous malformation with feeding vessels in the foramen of Luschka bilaterally, greater on the right than the left, coming into the fourth ventricle and within the spaces around the brainstem. Maybe there's a suggestion of some edema here within the right cerebellar hemisphere. FLAIR would be easier to see that, silhouetting it out from the CSF. I don't know what else was done. Don't know what this one is, but let's take a look.
This is perfect already.
Okay, yeah, no, it's a beautiful illustration.
The question is, would this be feasible to see this on low field? And that's why we put him afterwards into the low field scanner. And we did 2 low field scans. And one thing was that we wanted to show here, because we talked to him and his mother could talk to him, and he could also watch a screen on a phone during low field scan. He didn't need any sedation or anything to undergo. So that's a big advantage compared to low field to high field, where of course he had to be sedated.
And we
So
used
let's
the T2
take a look and answer the question.
2 minutes, so
Yeah.
that was very fast for us
Exactly.
to see, is there any progression or something like this?
Yeah, exactly. So he only needed, the second scan was only T2 fast within 2 minutes or 2.5 minutes.
So I don't know which one. This is probably the first one, since it looks like a regular T2. But again, let me zoom out, make this a little more contrasty. And while we don't have the spatial resolution that we had at 3T, we do see abnormal vessels due to this black blood angiography, to use the term, indicative of it. So it's kind of telling us the same thing. If there was an epiphenomena and edema, due to one of these thrombosing or something, I would think that we would see it to the same extent. So I think we are seeing it clearly, not again to the same resolution, but nonetheless. And it looks like there's either edema or volume loss here. I would need a flare to separate the two.
And the cool thing was, as we just said too, that we could do a second scan very quickly afterwards, and did only one very quick T2 because his headache didn't go away. And then that was easy then to see, I mean, does he have a bleed there, or does he have any progression or any other disease that would mimic, or other ongoing disease that would mimic? And, you know, he didn't need any sedation or anything for it. And we thought that was really something cool to use the scanner for as well.
I think this might be that same one. I don't know. This looks the same. So you had another one that was...
Yeah, an earlier one. That's this.
Earlier.
I think it's just above it there. Yeah, there you go. That's probably it. That's the first one. Yeah.
So this one that you just showed was the 2.5 minute T2 fast, which, you know, it's incredibly sharp in these older teenagers or older kids. I mean, he was only 4 years.
So it's this one?
Yeah.
That was the first one, yeah.
The first one.
Yeah.
Someone load it so it goes faster. Still not this one. I don't think this isn't the T2 fast.
I think this is the T2 fast in the axial direction. We only did T2 fast because he was...
Okay.
So there's like T2 fast axial, sagittal, and coronal.
Oh, I see. The multiply. So again, we're seeing the same thing. Here it looks like that T2 change around it, and I don't know if you did flare or not, is actually edema and not necessarily volume loss, because there's slight mass effect on the lateral wall of the fourth ventricle here. Not obstructing, but it's asymmetric. Like, I think everybody can appreciate that. Again, seeing the same thing. And if it's a 2-minute scan, you're answering your question. And if you did a T1, if he had hemorrhage, or, you know, you could assess the degree of that change in mass effect. And clearly with a lesion in this location, if it were to bleed, it could be subjected to acute obstructive hydrocephalus with obstruction of the fourth ventricle, and that significant mass effect and vasogenic edema. So warrants, I presume, he got some endovascular treatment or something.
Yes.
He got treatment.
Yeah. Do you remember what kind of treatment he gave?
I think coiling something like that.
Yeah, he got coiling of the
Coil. Do you want to see anything else, or should we?
Yeah, I think we're almost at the hour, aren't we? Or a little bit over the hour.
We're past the hour, but that's okay.
Don't worry. There's no,
Sean, it's early. For me, it's the middle of the day.
yeah, there's no fine for going over. It's all good. The concert can keep going. No, this was awesome. Yeah, thank you so much. I think there's a number of thanks coming in, you know, from a number of the groups that were present. I think, again, just an amazing tour de force that I think highlights both, you know, the utility of the system. It's improving utility as time goes on. I think you saw from the series of images, you know, just a general improvement, and some of that you know, obviously relates back to not only the team's increasing familiarity and getting kiddos in and keeping them still and getting them well positioned, but also obviously you know, improvements in the imaging software as things have gone on, you know, bringing the scan times down. I think some of the earlier T2s were about 4.5 minutes. Now they're down around 2.5 minutes and seem to be giving really nice information. And that might be a little bit lower even on some of the newer software. And then its utility then obviously in just tracking progression and really kind of finding things out which you might not be able to understand on a conventional high field system, where you might get one chance and that's about it. So I think, yeah, just a huge thanks to Dr. Sabir and his whole team, as well as Dr. Knopp for I think it was a great interplay between the two of you, and really kind of highlighting what you'd see on radiology and what you'd see and it would be important from a neurologist, neonatologist, or other clinical specialty. So huge thanks
for that, Sean, because I think clearly having Dr. Sabir and the team on, it adds so much more that just looking at pictures without that clinical information. And how it allowed them to affect the more appropriate treatment and guidance of treatment. It brings everything together. It's fantastic.
This was wonderful. So again, huge thanks again to all of you for taking your time out. Dr. Knopp, Hemmen, Anna. So just huge thanks to all of you. It was a really interesting night last night getting data up. So huge thanks obviously to our collective minds team getting data up, and apologies. Eddie, that's why you got the undefined MR. That was my fault.
Right. No, I know. It's okay.
I'll solve that next time. Don't worry. But yeah,
It worked. No problem.
huge thanks for all that. I can say that I think the next one we're going to try to do, we can obviously try to ask and plead with Hemmen and team to come back and do a follow-up with their immense other number of images. It's certainly not a B side. We're still on the A side. We haven't got through all those.
Big A side.
And then we might also consider some more adult scans looking at MS and neurodegenerative disorders. So a little bit on the other side of the aging spectrum for what Unity is focused on. But again, given that some of our sites are using these systems in sort of clinical practice, I think getting some of that information might also be useful. So lots of different things coming up on our image learning webinars. So please keep an eye out for that. Keep an eye out for emails and registrations. And again, just one last huge thanks to our collective mind team, Darren, Dan, Nathalie, Steve, obviously, PI, and then Hemmen Sabir, that whole team at University of Bonn Hospital, and Eddie and all the folks at Hyperfine. Huge thanks to everyone.
Thanks,
Thank you,
guys.
guys.
See you
Thank you very
again
much.
soon.
Okay. Take care.
All the
Bye-bye.
best. Bye-bye.